right, so let's talk about grading and staging. What does it mean by stage 4 cancer? That's what we're going to talk about now. Is that worse? Is that better? Okay. First, let's talk about grading. Grading is classifying what the cells look like, how undifferentiated they are. Is it just minimal or not? So we can talk about dysplasia. Is it mild dysplasia, where maybe 10% of the cells are just dysplastic? 50%? Are they 100%? So in this case, we're looking through a microscope to see what the cells look like. Okay? So how closely do they resemble the parent cell? Okay? We refer to it as grades 1, 2, 3, and 4, increasing in what we call, here's a new word for you, anaplasia. Anaplasia, basically it's this. We have mild dysplasia, just some cells that are changing. Moderate dysplasia, maybe 50% to 60%. Severe dysplasia is virtually almost, not quite, but almost 100% of those cells are dysplastic. Anaplasia, 100% are. There's not one cell there that looks anything normal. It's lost all its integrity. So well differentiated means that they're normal cells. Poorly differentiated or undifferentiated, now we call it dysplasia or cancer cells. Anaplasia means absolutely no cells look anything like the parent cell, not one cell. Okay? So anaplastic cells, very aggressive tumors, that's a grade 4. Notice I'm saying grade 4, not stage 4. That's different. Okay? So the more undifferentiated cells are, the poorer the prognosis. The closer it is to anaplasia, the poorer the prognosis. Okay? And it also helps to differentiate about the prediction that these tumors will respond well with chemotherapy or surgery or whatnot. So it kind of helps you with that. For example, we have tamoxifen. If there's a tumor that's affecting the estrogen receptors, we can actually, and the thing is, the estrogen receptors, estrogen wants to bind to these. So if there's, let's say, breast cancer. If estrogen is binding to the receptors of estrogen on the breast for breast cancer, it's going to turn them on, and it's going to make the cancer go faster and faster and faster and faster. So it would be nice if we could actually block that receptor so that the estrogen can't get and turn that on. Well, that's what tamoxifen is. Tamoxifen is a medication, a chemotherapy agent, that will actually block the estrogen receptors so that the estrogen can't bind there. And if they can't bind there, then this is going to grow slower and slower and slower. All right? So well-differentiated estrogen receptors allows tamoxifen to work well with breast cancer. If those receptors are so deformed and so dysplastic, the tamoxifen is just not going to do anything. It looks for estrogen receptors. If it looks like a trash can, it's not going to bind to it. Does that make sense? All right. So this is just showing you what normal liver cells kind of look like. And you can see here, even in the distance, they're much darker. They stain differently. And I'm not going to give you pictures on the exam, or quiz for that matter, but just trying to illustrate what we're talking about here. This is what normal cervical pap smear would look like. It looks like cells like this. And here's one that has a malignancy going on. That's what we look for when we do pap smears. They look different, not just the color, but even the way that the nuclei are. Okay? Okay, so that's grading. All right? Grading is looking at the individual cells. You need a microscope. Staging is different. In this case, you want to see how far it's spreading. So it's not really on a microscopic level. It can be, but we could use other things. It could be clinical to see, if you have lung cancer and then all of a sudden we could actually feel a bump in the bone, then maybe it's been spread to the bone. So it's clinical. It's not we're looking with a microscope, right? So we could use radiographic. We may have to use CT scans to see if it's spread further, or surgery. We remove the tumor, but we also want to remove some of the lymph nodes, distant lymph nodes. If those distant lymph nodes actually show cancer, then it's spread. Now it's a different stage because it went that far. So every cancer has stages 0 to 4. 4, always, stage 4 is always metastases. It's always someplace distant. Stage 4 is the worst. Stage 0, it's really like a carcinoma in situ. It's really staying right in there, okay, right where the primary site is, okay? Stage 4, like I said, it'll always be distant metastases. The stages actually guide the doctor to choose what treatment is best. For instance, and I'm just giving you examples, I don't know exactly, but let's say for lung cancer, if the doctor diagnoses a person with stage 2 lung cancer, then he looks at the records of what the studies, because it's all based on studies, what's the best treatment for someone who's got stage 2 lung cancer? And they see that the best treatment is, let's say, I'm not too sure, lung cancer is not my specialty, but lung cancer might be, let's say, chemotherapy. So that's what we say. You get a better prognosis if you use chemotherapy for stage 2. If the person had stage 1, studies show that you get better prognosis for just surgery. So kind of stages tell you what treatment is best for that particular cancer. Because every cancer, I can't say what cancer is for, let's say, stage 1 or stage 2. It depends on what cancer we're talking about. But there are certain rules that we do try to follow. So there's 2 methods of staging. One method is by the American Joint Committee, all right, AGC or AJC. Stage 0 is always carcinoma in situ. Okay, always. The carcinoma in situ has to be an epithelial origin. Okay, so if it was a connective tissue, you wouldn't get a stage 0 because there is no carcinoma, it's sarcoma. There's no such thing as sarcoma in situ. Stage 1 is localized invasion with no lymph nodes whatsoever. Okay? Stage 2 is localized and only the nearby lymph nodes are involved. Stage 3 is spread to nearby organs or distant lymph nodes. But stage 4, if it's in your lung and it went to your bone, that's very far. That's stage 4. Okay? So you should know those stages in general. We could also refer to it by the World Health Organization came up with this TNM stages. Okay? And it's an acronym. Not really an acronym, abbreviation. T stands for tumor spread, N for nodes, lymph nodes, and then M if there's any distant metastasis. But these could actually, and I wouldn't hold you up to this, but these can go, let's say, T0, T1, T2. It gets really complicated. But in the medical realm, or if you're going to be a nurse working in oncology, you'll learn all these. But I'm not going to ask you all about that. These you should know. These are pretty straightforward. Okay? So staging, just to show you an example, staging for cervical cancer. Stage 1 is, well, it could be, let's say, stage 1 is carcinoma in situ, but if it actually stays in that area, all right, we can call it stage 0, stage 1. Stage 2 is cervical carcinoma where it broke the basement membrane. All right, in that case, we have to take a biopsy of the cervix, and we got to see what actually happened. See it like this. Stage 3 is that the local organs, the top of the superior end of the vagina has got some of the cancer now. But if it spreads to the urinary bladder, which is still far from where the cervix is, or the rectum or bone, that's stage 4. So is the zero. This is the staging by the AGC. That's universally accepted as much as the TNM is. So there's two staging going on. Okay? You don't have to worry about the zeros. Just understand what the TNM stands for. Okay, it's another way. When you get into these fields, if you get, let's say, NCLEX question about TNM, you have some idea what that is. But you won't have to memorize all those things. Okay? So grading versus staging. And what's better between the two? Well, staging has proved to be more of a greater clinical value. It helps much more with treatment, and it helps much more with estimating the prognosis of that cancer. So it's usually based on a 5-year survival rate, meaning that if you have, let's say, and I'm just giving examples again, that if you have stage 2, if you have stage 2 lung cancer, they've done studies and they realize that the 5-year survival rate is that you may, I'm just giving examples, you may live, or let's say for the 5-year survival rate, there's a 75% chance that you will be here 5 years later. Stage 3 lung cancer, they might say, well, you got like a 45% chance of being here 5 years later. So we usually base it off of what we call a 5-year survival rate. So that you've heard stories. It doesn't mean that all the time it's going to be that way. How many times you hear these stories on TV and movies and maybe even yourself where they say, oh, the doctor gave me three years to live, and now it's like 8 years. You know what I'm saying? These are just estimates. It's not clear, but that's what they're dealing with. When they decide what stage you are, then they're doing it from these studies that studies show that 75% will live the next 5 years. Not 100%, right? Okay, so diagnostic and monitoring tests for neoplasms. We can do cytological tests. Fine needle aspiration. You do a self-breast exam, you feel a lump there. You talk to your doctor, the doctor feels a lump there too. He's going to put a needle in there that has a borehole, in other words, it's hollow. Put a needle in there, hopefully get some tissue, and send it off to the lab. That's a fine needle aspiration. Sometimes he can't, it's too deep to actually feel it, so he'll put an ultrasound there, and he can watch with the ultrasound where the needle's going. So it's what we call an ultrasound-guided needle, to see where it's going compared to where the mass is that they got to get. Okay? Bone marrow aspiration for the people with leukemia, take a biopsy of that. Pap smear is basically removing some of the cells and just scrapings off the cervix. Frozen section. We see this in the OR quite a bit. If you're going to be a nurse in the OR, they're going to be actually doing, let's say they do an appendix, they remove the appendix. They do an appendectomy because the person's got appendicitis. But they also noticed as they were doing that, they saw this mass on the colon. They've never seen this before. So what they might want to do is remove a portion, a biopsy of that tumor. It's an incidental finding. We weren't expecting that. And then send that down to the pathology while the person is still under anesthesia for the next 15 or 20 minutes. Hopefully they're going to get back a preliminary report from the pathologist and say, no, everything looks okay. It's preliminary. It's not 100%, but he might just say, or she might say, you know what, it's definitely cancer. So you might want to go and talk to the family member and see if you need to do anything further or remove certain things. I don't know. But that's what a frozen section is, something like that in the OR. You see that quite often in the OR. All right? Some tumors release certain specific markers. We call them tumor markers. That looks very specific for that particular tumor. There may be certain hormones, enzymes, there might be genes, antigens, antibodies. For instance, well, the tumor markers can be used for screening individuals, and I'll show you examples of that. Could help with diagnosis, observe clinical course of the cancer. In other words, let's say we do a PSA on a certain person who's got prostatic cancer. PSA is prostate serum antigen. Okay? this comes out of the prostate. But it comes out of the prostate not just in cancer, it comes out normally at a very low rate. It could come out during hyperplasia, where it's just benign prostatic hyperplasia. It's just growing large. It's a benign tumor. All right? When we get into male reproductive, we'll go further into that. But you have this PSA that comes out. Right? Just an antigen that kind of comes out. We remove, and let's say it was like 12, which is pretty high. Well, 10 is high. It turns out to be cancer, we remove the cancer. Now it should be going down. So we'll be watching it. It'd be nice if we got 100% of the prostate, but it's never like that. It's usually about 99%, 98%. So there's something that could have been left in there. So we're watching it. So every year they're going to get a PSA. It should stay low. If it starts going up, then we got to go back in and see what's going on. So we could use that to see if the treatment is doing well. Maybe they not go back in, but maybe they'll use radiation instead. Okay? The problem is with these is that there's a lot of false positives and there's a lot of false negatives. So they're not totally reliable. For instance, there's a certain tumor that of the ovary that releases beta-HCG. The problem is beta-HCG also comes out of pregnancies. Now, granted, if we're checking that in like an 80-year-old woman, all right, that's probably what it is, probably some sort of cancer. If it's a 35-year-old woman, we're not too sure. Chances are it's because she's pregnant. So they're not 100%. There's a lot of false positives, there's a lot of false negatives. These are the ones you should know on here. That's the one I just talked about, prostate-specific antigen, I thought it was serum, but specific antigen, alpha-fetoprotein, CA125, CEA. These are the more common ones that you see on boards, okay, and what they test for. But like I said, I mean, just having a CA125 in the ovaries, endometrium, breast, lung, it could be all over. So it's not specific to that, okay? Radiology tests, right, CAT scan, you know all these MRIs. You can do these to help with that. Now, treating cancers. We may treat for cure or palliation. You guys know what palliation is, right? That was in Nursing 101. No? Palliation is to make the patient comfortable. All right? We can't really do much, but we're just making her comfortable. She's in a lot of pain because of this tumor's growing. But we can't do anything about the tumor, so we're going to give them some morphine for pain medication. We're treating to make the person comfortable, not for the actual tumor. All right? Palliative care or palliation. Okay? A lot of hospice is really known for doing a lot of palliation because they're in hospice, they're dying, you can't do much more than just make them feel comfortable. Okay? We can either do surgery, radiotherapy, chemotherapy, or something called immunotherapy, or a combination of that. And all of this is based on studies. What's the best, if this is stage 2 lung cancer, what's the best one? Well, surgery, and you also add this in it too. So you have combinations of this, okay? So surgery, we could do, this is the most common treatment, MC is most common. This is the most common treatment, and we usually do this mainly for debulking. What that means is, and they usually put an adjunctive chemotherapy to it. In other words, the chemotherapy, which is a chemical through the IV, all right? Now, keep in mind, too, chemotherapy does not mean just for cancer patients. Anything that's chemicals that's going into your body is chemotherapy. An antibiotic is chemotherapy, all right? But I think there's a misnomer that people think that chemotherapy is only cancer. It's not. Well, let's say this person gets chemotherapy for this cancer, but you know what? It's going to work, but the tumor is so huge. We've got to put a big dose of chemotherapy to get that down. But the dose is so huge that it's going to cause too much side effects that it's going to kill the patient. So why don't we take this tumor and cut it down to like 10%? So you went from 100% down to 10%. Now, that's what I mean by debulking, so that the chemotherapy will be more efficient and have less side effects. Does that make sense? We call that debulking or cytoreduction, cell reduction, and that's what it's doing. So Surgery is also to prevent cancer. We see some polyps there in the colon. Most of those polyps are benign, but they're not going to they're going to see 2 or 3. They're going to remove them because there is a chance that they could become cancers. Biopsies for diagnosis and staging. And we also want to remove some lymph nodes to see how far should we, again, for staging, to see how far this cancer is spread, if it's spread to the lymph nodes. And like I said, also for palliative surgery to make the person comfortable. Radiation, goals is to really eradicate the cancer, but not destroy good normal cells. Okay? Have you ever heard of someone having, let's say, lung cancer and they have a tattoo now? Any of you heard that? See, the thing is, if you have to go for, I'm just giving an example, 10 treatments, 10 radiotherapy treatments for lung cancer, that means once a week you got to go in. Well, you need to make sure that you're hitting the same spot every time. One, to make sure you're giving the dosage and kill that damn cancer. And two, you don't want to be off even a millimeter and kill off good cells. So they will, if you have to go for radiotherapy for these sessions, they will put a little tattoo on that spot. Now, it's not a bird or a butterfly. It's usually just a dot. Big enough that they can see where that is, but small enough that you won't even notice it unless you know it's on it. So that they know that's where they're going to shine the light, and that's where it'll go every time for all your cancers. All right? And that's what they do, to try and avoid damaging normal structures. Okay? And the cancers, damages the cancer cells. Okay? We don't see much radiation therapy go into children. They do it, but not as often as adults, because children, their bodies are still developing. So we don't want mutations to possibly happen when it's still dividing when it shouldn't be. So we wouldn't. We see it, but not as often as an adult. Okay. Chemotherapy, again, it takes advantage of those cancer cells. And we usually give it combinations. But like I said, we could also do adjunctive chemotherapy with surgery. Surgery is just going to remove, hopefully 100%, but it's never that way. So it's usually like 95% or something. And the other 5% or 2%, the chemotherapy will go through the whole body trying to kill off that other 2 or 3%. So sometimes they use that too. Okay. Immunotherapy, a good example of this is vaccines, and the one you see all the time right now is the big old HPV, right? The Gardasil, for HPV causing cervical cancer. And these are the ages. 3 doses you get, these are the ages that they do it on. Okay? That's an FYI about the ages, but if you have children, that's what it's all about. Because that's relatively new. They came up with the past 5 years, just not happening well. So the HPV vaccine, there are vaccines that they're trying to come up with, but the success rate is just not happening well. So the HPV vaccine is kind of a hallmark to say that it is possible that we can do this, but they got to do more studies on that. Okay. Other terms, remission is a period of time where there is no more symptoms. It seems like you're treated, but you're really in a remission until it comes back again. Now that when it comes back, it might be 10 years, might be 2 months, might be 20 years. It might be 50 years and you die 40 years later only because of pneumonia and never saw it again. So I would say that you always have cancer, it's just you're in remission. You live with cancer. It's just the treatment is cutting it down so that it doesn't get excessive, that you can't do normal things. If you've had cancer, you have it. You just have to always go back and check it. And when it comes back, we call it a relapse. Okay? Hopefully that doesn't happen, but sometimes it does. Okay, so that's cancer.